Welcome back to this evening's webinar. I'm Dr. Kirsty Smith. It is a great pleasure to welcome back Dr. Ceri Millette for another talk in our webinar series. Ceri is an ST7 in geriatric medicine. Last year, Ceri was one of the first Thames Valley Quality Improvement Fellows, and her focus was on supported return to training. Tonight, Ceri will be sharing with us her prescribing top tips.
Thank you, Kirsty. Can you hear me okay?
Yes, it sounds perfect, really clear.
Fine. I've also got Fiona, who is another Jerry's ST7, who is going to answer questions as we go along if people have them. And just to say that this isn't a Jerry's prescribing talk, much as I would love to do one of those. It's a general top tips of prescribing. So we were asked to do loads of stuff, and we clearly can't cover everything. So I'm sorry for those of you who I don't cover what you wanted. I'm just going to signpost to where things are covered elsewhere. So fluids was done in the AKI talk. Insulin, you've obviously just had from Ryan. There was some specific stuff about COVID that Dr. Ramasamy covered. The emergencies, so things like anaphylaxis are under ALS, and also the approach to the breathless patient. Sinit Raja covered COPD prescribing and asthma prescribing. Palliative prescribing was covered in the end-of-life talk given by Catherine Ashton, and some of the cardiac prescribing has been covered in the ECG and arrhythmias talk, and there's also been a specific epilepsy talk for seizures. So with that in mind, there's still quite a lot to cover in 45 minutes. So the things I was asked to talk about, so some antibiotic complexities, anticoagulation, potassium, drugs that you shouldn't miss, antiemetics, laxatives, analgesia, and then a fun quiz for a Thursday evening. So starting with antibiotics, I'm not going to sit here and say to you, this is what you prescribe for a chest infection, this is what you prescribe for a UTI, because all of your trusts will have their own guidelines and we all look at them all the time. So in a lot of trusts, they have ones that you can get on your phone and you just need to download them and use them, and there's no shame in using them. Most people do not know them off the top of their heads. The things that apply to all antibiotics, so please document the indication, because I'm sure you had a very good reason for it, but if I come in the following morning and I'm like, why are they on this? Then it will probably get stopped. And also a course duration, so they don't end up on it for ages. And if you don't know how long it's going to go on for, that's fine. Like when you're in A&E, you can't predict how this is going to go, but just at least put a review date on. It sounds so obvious, but don't forget allergies. We've all had that moment where the nurse comes up to us and says, do you know this patient's allergic to penicillin? Just a few thoughts. So nitrofurantoin is not much use if the EGFR is less than 45. We had this come up on our ward round the other day. Some antibiotics, particularly Camoxiclav, can cause a cholestatic picture in the liver function tests. It's always worth keeping an eye on that, but maybe not getting too worried about it. And hold your statins when patients are on clarithromycin or erythromycin. And we'll also talk about some anticoagulant interactions as well. So the specific things that I was asked to talk about was the complex dosing that you quite often get called about out of hours. So gentamicin, teicoplanin, and vancomycin. So gentamicin dosing, why do we care? Why are we so precious? So everyone, you all know, we're worried about nephrotoxicity and to a slightly lesser degree ototoxicity, although I have seen it. So there is a guidance. You should always look it up. Like, that's fine. You're not expected to know this off the top of your head. The reason for through this is it's quite complicated. So I wanted to just remind people of how you use the guidance. So for most people with a creatinine clearance of 60 and more, you're using 5 mg/kg. And just a point, that's a creatinine clearance, not an EGFR. So you do actually need to go and do the creatinine clearance. You don't need to do it with your pen. Just find a calculator on MD Calc or probably on your computer. But remember this. So the frailer patients, those at higher risk of renal impairment with a creatinine clearance of 20 to 59, you're doing 3 mg/kg for their first dose. And to be honest, that's pretty much what I use on my ward the whole time. So that's fine. That's your first dose. And it may be that that's all they need. But if you've got someone who's going to be on longer term dosing, then you need to be checking their levels. And this is where you get called out of hours, because of course, it inevitably ends up that it doesn't happen on the ward day. So what happens is after the second dose, bloods get taken 8 to 12 hours afterwards. And then you'll get called and say, oh, Mrs. X's gentamicin levels this, what do you want to do? So let's say that it was 12 hours afterwards, because it always is, because we never get round to it. And the level was 4. So that puts us in this area here, which is 36 hours dosing. So that means after your second dose, your next dose will be 36 hours later. And the guidance is that you then repeat it after alternate doses. So you'd be repeating it after the 4th dose here, which ends up actually being 3 days. So that is how you dose gentamicin when you're asked to do it. The one that's even more complicated is vancomycin dosing, which just makes everyone's brains hurt. And it doesn't really need to. I think it's the trough level that gets us. So why do we care about vancomycin? Same thing, nephrotoxic, ototoxic, also can cause blood dyscrasias and can cause rash as well. So the initial loading dose is based on weight. And I haven't put that up there because I don't think it's particularly taxing or stressful. You look it up on the computer, you don't do it off the top of your head. And it's somewhere between 1.5 and 2.5 kilos based on their weight. And that's your loading dose, and that's fine. But then you have this complicated thing of when you give your next dose, your initial maintenance dose. And that is based on your EGFR. So let's say our patient has an EGFR of 50. That puts us in here, which is a 12-hour dosing, so a twice daily dosing. So that's fine. We put them on a twice daily dosing. And then we say, right, so when do we need to check the next level? We go down here. We're on twice daily dosing. So we take our blood sample before the 4th maintenance dose. So you give your loading dose, 1, 2, 3. Just before you give number 4, you take your trough level and then you give number 4. And that's where you get problems, because you get called and no one's given the 4th dose. And then you're like, oh, now what do I do? And in that situation where it's been messed up like that, the answer is you call micro, because that's what they're there for. But assuming it's been given properly, the 4th dose gets given. You then get called saying you've got these levels. And the trough level that you want is 15 to 20. So if you're sat at the trough level, then you continue with the current dosing, which is twice daily for our gentlemen. But let's say that the trough level is high and you've taken it at the right time and it was definitely a trough level, because that's the other thing you have to check. Then you reduce it, you go back to your original loading dose and you reduce it by 1 weight band. And if they're so light that that ends up taking you below a recommended dose, then it's time to contact micro. So that's how it works. There's also guidance for if you have severe renal impairment, most of which ends with and call micro. I'm not going to talk about teicoplanin because it's pretty much exactly the same concept of trough levels, picking a weight, picking a level, and you normally only have to check teicoplanin after 7 days as well. So you don't need to worry so much about that. Okay, so I told you this was a whistle-stop talk. So the next thing that I was asked to talk about was anticoagulation. And I know that Jamie touched on it a tiny bit, but I just thought I'd expand on that a little bit more. So the majority of the time that you're going to be starting patients on anticoagulation, it's either going to be for atrial fibrillation or a PE or a DVT. PE and DVT is pretty straightforward. They need to be on anticoagulation. Atrial fibrillation is a little bit less straightforward. So those of you who started your training about the same time as me will remember the CHADS score, and then they added on some extra bits to be the CHADS-BASC score. And these are the risk factors of how you decide if your patient in atrial fibrillation is someone who should be anticoagulated. And paroxysmal atrial fibrillation should be anticoagulated just as much as persistent atrial fibrillation. So just because you saw it on one ECG and not on the next ECG, don't think, oh, they don't need anticoagulation. In fact, that's probably worse in terms of clot generation, in a sense. And peri-op atrial fibrillation, we tend to anticoagulate that as well. So these are the risk factors, and the eagle-eyed amongst you will note that being a woman gives you a point of 1, and the guidance is that you should consider anticoagulation if you have a score of 1, and you should recommend it if you have a score of 2. Seems a bit rough if you're a woman. So what they say is, if your score of 1 is to do with being a woman, that's the only thing you're getting a score for, you can ignore that. You don't then need to recommend it. And you can find this on MD Calc. No one's expecting you to remember that off the top of your head particularly. Just a point that up until a few years ago, we used to use aspirin in atrial fibrillation. We'd say, oh, we don't want to give them warfarin, it's a bit risky, we'll give them aspirin. We don't do that anymore. The risk outweighs the benefit of aspirin. There's more bleeding than good done. So if someone's on aspirin just for AF, just stop it. It's not doing them any good. We then got the has bled criteria, which is the other side of the coin. So what's their risk of bleeding? And that gives you a bleeds per 100 patient years. And again, you'll notice that actually you can score pretty similarly for the same thing. So hypertension here, stroke here, elderly, over 65, maybe a bit harsh to call it elderly, but elderly here, and age 65 to 74 here. So you can get very equivalent scores, and they're only a guideline. Nobody, I think, if you're coming back into practice, is expecting you to weigh all this up and make the decision for the patient and then counsel them on everything. But what would be really helpful is if you see someone with AF to go, they might need anticoagulation. I'll do a CHADS, VASC and a has bled, and then present that to whoever is making the decision and doing the counselling. So in terms of what we use for atrial fibrillation PE DVTs, so DOACs are licensed for AF, for PE and for DVT, but not for heart valves. So anyone who's got a heart valve will still be on warfarin. And for some people, DOACs will be new. I went away on my first maternity leave and came back and everyone was on a DOAC and I didn't really understand them. And I was initially a bit worried about them as well, but actually they're great. So we tend to use warfarin in patients with liver dysfunction, severe renal impairment, generally in a weight over 120 kilos, because the DOACs just aren't really validated there, although on a patient-by-patient basis, you can discuss with haematology. Reasons that you might change somebody who's already on warfarin to a DOAC. So mostly the guidance is if someone's on warfarin and they're happy and they're well controlled, don't change them. If their time in the therapeutic range is less than 65%, so if their target was 2 to 3, and you were finding that 65% of the time they were out of that, you might consider switching them to a DOAC. And also, I've had some frail older patients who are going to get blood tests is a real issue. And so those patients as well, sometimes you can switch them to a DOAC. So the DOACs are apixaban, edoxaban, and rivaroxaban. And the reason I'm stressing the XA is because that's how you know it's a 10A inhibitor. If you want to look clever, know how it works. And dabigatran with the T as the thrombin inhibitor. I'm not going to talk about the dosing of specific ones, and that's because every trust uses different ones. So if you think, oh my goodness, how will I decide? The answer will be your trust will tell you what they want you to use. Our trust, everyone goes in apixaban. It's actually really easy. The things that I think you should think about is make sure that you're not underdosing them. And the reasons people might be underdosed is, for example, with apixaban, we use a different dose for some patients for AF than we do for PE or DVT. So you need to know their indication. And you need to look at their age, their weight, and their renal function. And sometimes people think, oh, they're old, I'll reduce the dose. And that's not right. So just be a little bit careful they're not being underdosed, I guess, or overdosed. In terms of reversal age, and the other thing to tell them is that they must take it every day, twice a day, if it's twice a day, because if they miss a dose, they will then not be anticoagulated. It's not like warfarin where it takes a bit of a while to wash out of the system. So for DOACs, the only reversal agent that we have in this country is for dabigatran, which you can get in Aimee. For all the other DOACs, call haematology, and in fact, even once you've given the reversal agent for dabigatran, call haematology, and they basically decide what you're going to give, whether they're going to give prothrombin complex, which is also called Octaplex or Veriplex, or whether they're going to give FIBA. Neither of them are particularly evidence-based, but anyway, that's what we do. And for warfarin, we have something we do know works, so we have Octaplex, Veriplex, PCC, and we also give vitamin K as well. So I was specifically asked this question. Mrs. Wise, warfarin needs a dose review. Classic on-call annoying question. So things to think about first, and I would say that for those of you who were doing this 5 years ago, there's a lot less of this now because we have DOACs. But things that you want to find out, you want to know why they're on it. Is it for a mitral heart valve where actually the risk of clot's going to be really high? Is it for a recent DVT that was unprovoked, or actually is it for atrial fibrillation, which is a bit of a softer indication? What their normal target INR is, what their normal doses, are they well controlled most of the time? What's their most recent INR? Sometimes it will be it needs a dose review and their INR was fine, and actually they've got a set dose already and you don't need to mess with it. And actually, is this an interruption that someone had planned? Is someone planning on doing a procedure on them tomorrow and they wanted it to be held? And is that documented anywhere? It's also worth, when you're looking at people's INRs, thinking about drugs that mess with warfarin. So when it's all gone funny, you can think, why has that happened? So you might remember these mnemonics. So O devices and PC bras. I'm not going to go through them all, but O devices ones are the ones that inhibit cytochrome P450. So they increase the effect of warfarin, you get high INR. So the examples that particularly we use a lot are erythromycin, ethanol acutely, so an ethanol binge, and omeprazole. And then PC bras are the ones that decrease the effectivity of warfarin, and phenytoin, chronic alcohol use, and sulfonylureas. So bearing all that in mind, the way that warfarin is prescribed, and it is prescribed by the anti-coag clinic. If you are starting warfarin, you will be liaising with the anti-coag clinic and you will be going into the trust guideline and using whatever your trust loading guidance is, which varies slightly, but is somewhere around 2s and 3s or 5s and 10s, depending on what you're prescribing it for. So you don't need to remember that. But essentially what the anti-coag clinic does is it works out the dose that they want the patient to take over a whole week. So in this case, it's 32 milligrams, and then they divide it up as evenly as they can over the week. So 5, 4, 5, 4, 5. So that's 32 milligrams. So that's what your patient's on normally. So then let's say that you're asked to check the bloods for a patient in a 2 to 3 range. So their target INR is normally 2.5. And you come along and you're asked to check the INR and their INR is 3.8. So that puts you in this bracket here. So the guidance is that you decrease the overall weekly dose by 10%. So in order to do that, the weekly dose is 32, you minus 10%, which is approximately 3, it's 3.2, so minus 3, which gives you 29, and you then write it out again, working out what 29 would be divided over the week, and prescribe a dose that evening, and repeat it in every 24 to 48 hours. That might slightly depend on what else you know is going on with them. If, on the other hand, you've ended up way down here, so for example at 1.5, then the guidance is to increase the weekly dose by 20% and monitor the INR daily. But you should also think about whether you need to bridge them with treatment dose low molecular weight heparin. So for patients who've had a PE and a DVT, that's probably quite important. You probably want to use treatment dose low molecular weight heparin. For patients who've had atrial fibrillation and might have a bit of a high HADS-BLED score, you might think, actually, I probably won't give them treatment dose low molecular weight heparin, but I might give them prophylactic deltapargarin. And I would argue that if someone's in hospital and they're unwell, then they should at least be on prophylactic deltapargarin until their INR comes into range. And I think if it's complicated and you've got in a pickle, then you've looked at this and you still can't work it out, then it's fine to call the med-reg. And I don't mind about one of these patients, I don't mind answering questions if it's really got in a muddle. But I think the guidance is a lot clearer now than it was sort of 5-10 years ago. Okay, potassium, just because people get a bit excited about high and low potassiums. So hypokalemia, so low potassium. The first thing to think of is why is it low? It's probably going to be diuretics, and it might be that you want them to be on those diuretics. It's a desired effect, and you're just going to put up with it and give them some Siddiqui. You might think about whether you could give a potassium sparing diuretic though. So spironolactone or a miloride, for example. And that, out of hours, that doesn't need to be your decision. You can just give them the potassium and then, you know, say maybe someone else can think about this. So oral replacement is Siddiqui, 2 tablets, 3 times a day. If it's less than 2.5 or they're symptomatic, then you want to give it intravenously. And in practice, a lot of patients in hospital have a Ventolin in, they're having some fluid anyway, so you can just put potassium in the fluid. Just a reminder that the maximum you can give through a peripheral Ventolin is 10 millimoles of potassium an hour. So that's, for example, a 40 millimole bag, the fastest you can give it is over 4 hours. Then if they're hyperkalemic, the first question is why? Because you can do all of this treatment down the bottom here, but actually if you don't deal with the problem, then you're just gonna, it's just gonna keep going high. And as a house officer, I once spent a whole weekend treating someone for high potassium, and the consultant came in and crossed off their spironolactone on Monday, and I felt a little bit silly. So I quite like this chart. I took this off Twitter. If your potassium is 5 to 5.9 and you don't have any ECG changes, then that is mild hyperkalemia, and you can repeat it tomorrow. You don't really need to do anything else. If they've got ECG changes and you're there, then you want to be giving them some Act Rapid in 50 mils of 50% dextrose to try and bring it down, and thinking about the cause. And if you're these ones over here, so you're severe, then you want to give them calcium gluconate, which used to be 10 mils of 10%, but is now 30 mils of 10%. And that's to protect the myocardium, and the 10 units of Act Rapid and 50 mils of 50% dextrose. And you can also give salbutamol nebulizers, which will drive potassiums into the cells. But again, you're not really treating the problem. So if the reason they're hyperkalemic is that they need dialysis, then you kind of need to deal with that. If they're on digoxin, then you need to infuse your calcium gluconate slower. So there's a risk of myocardial toxicity if you give them digoxin too quickly. And those are the key things about potassium, really. This is one of my least favourite bleeps. Mr. X is hypertensive. What should I do? And 9 times out of 10, the answer is nothing. Go and have a cup of tea. So the first question is, why is Mr. X hypertensive? Is he in pain? I'm obsessed with the fact that actually mostly people are hypertensive in hospital because they're in pain. Has he missed his morning medication of losartan that would in fact mean he was no longer hypertensive? Are we measuring using a smaller blood pressure cuff than we should be, for example, on an obese patient because we can't get hold of it? And manually as well is another way of doing it. Do they have any symptoms? So if they've got a severe headache or focal neurology or eye signs, then I'm more interested in their high blood pressure. Realistically, you're not going to get that below 200. And to be honest, if they haven't got any symptoms, then even if it is 200, I'm not actually that frantically bothered. The times when I am bothered about a blood pressure, a high blood pressure of 200, is if they've had a stroke. So we're actually pretty permissive with blood pressure. If they've had an ischemic stroke, we like to aim less than 200, but we don't control it more tightly than that. If they've had a hemorrhagic stroke, then we like it somewhere between 140 and 180, depending on who you work for. And the neurosurgeons like unsecured subarachnoid hemorrhages less than 140. In these circumstances, you want rapid control. So you want labetalol or a GTN infusion, and you definitely want to look up the departmental guidelines for that. And that's fine. And in fact, if you're not sure, then you can phone a friend for that one. That's okay. If this is a long-term problem and they've got a high blood pressure and it's worrying everybody, then you can give them a little bit of amlodipine, 5 milligrams. But amlodipine doesn't work particularly quickly, so don't be surprised if it doesn't come down in the next 2 hours. So apart from this bit, these bits here, you can actually be a bit relaxed about high blood pressure in the on-call setting. Drugs never to miss. And I'm sorry, there will be specialists out there who are really grumpy with me because I've missed one of their really important drugs, but these are the ones that Fiona and I thought were really important. So Parkinson's disease medications. If they are nil by mouth, either put down an NG tube, if that's going to be appropriate, or put them on a rotigotine patch. And what you can do is you take the medications that they're on and make sure you find out all the medications they're on, and you put it into this calculator called Optimal that you can find online, and it tells you what dose of reticotine to give. And then the nurses will say, oh, we don't have it. And that's when you're allowed to call the on-call pharmacist in from home and have done. So we don't have it is not a good excuse for Parkinson's meds. It's not acceptable. Ditto anti-epileptics. One of the times they call the on-call pharmacist in from home. So if they're too drowsy to take their anti-epileptics, then you might need to do an IV conversion. Keppra converts to IV, phenytoin converts to IV, but lots of them don't. And I've spent ages in resus rummaging through the BNF, ringing neurologists, ringing on-call pharmacists, and those are completely appropriate questions and completely appropriate phone calls to make. Don't let people miss their anti-epileptics. You'll just end up in a terrible pickle. If they're on long-term steroids, unless you've got a specific reason that you're not giving them to them, please don't let them miss their long-term steroids. So if they are on, they say more than 5 milligrams normally, then consider doubling it if they're unwell, because they may not have an adrenal response. The immunosuppressants for transplants, don't touch them. Just call the team, please. Which, you know, if it's a renal transplant, will be the renal team, and they'll probably have you doing tacrolimus levels. But really, and contact the teams early. Transplants are so precious. And I wouldn't say never miss, but caution with drugs with recognised withdrawal syndrome. So, for example, benzodiazepines, opioids, those kind of things. I am all for weaning these drugs down. As a geriatrician, I am not pro them, but you just need to maybe not stop all of them cold turkey. Okay, antiemetics. So everyone will have their favourite antiemetics. These are probably the ones that I tend to use and I'm most familiar with. They use slightly different ones in palliative care. And so this is more for the general ward. I actually don't use domperidone a lot. There was a recent MHRA warning about long-term use and cardiac problems, but we do sometimes use it for Parkinson's patients who are starting on Sinemet, which can make you feel a bit sick. Cyclizine, I quite like, 50 milligrams TDS. Risk of tachycardias, I wouldn't give it to someone in fast AF, having seen it go quite badly wrong. And I think it's also worth noting that sometimes patients will come in and they'll say, IV cyclizine is the only thing that works for me. And that suggests to me a degree, perhaps, of euphoria-seeking behaviour. I'm not saying it always is, but it's worth thinking about. Metoclopramide, please avoid in Parkinson's disease and also in GI obstruction, because it's a prokinetic, so it will stimulate your bowel. The only caveat to that is end-of-life care in bowel obstruction. We do use metoclopramide, actually. Ondansetron tends to be a post-operative nausea and vomiting and chemotherapy drug, but you can use it elsewhere. Just to be aware of QT interval prolongation, which particularly given the drugs we're giving in COVID, like hydroxychloroquine and azathioprine, might be an issue, and it can be quite constipating as well. Which brings me to our next topic, and one of my favourite topics, and I've tried really hard to keep this to one slide because I could talk for an entire talk about this. Constipation. So my personal regime that I like is Senna 1 to 2 at night. It's a stimulant laxative. Give it 8 to 12 hours before they would normally open their bowels. So if there's someone who normally goes at 6 p.m. every evening, please give it to them in the morning. But mostly we give it to them at night, and only use it for kind of 2 weeks. Because if you use it longer term in adults, there's a risk of theoretically atonic gut. And then Laxido, which I do really like, which is an osmotic laxative, and 1 twice a day. The only problem with that is they do need to be drinking enough water, but hopefully if someone's constipated, we should be encouraging them to drink anyway. It doesn't work for everyone. It doesn't always work for elderly people. So you can use lactulose 10 mils BD if they're not drinking enough, but it causes a lot of bloating and flatulence and can be quite uncomfortable. You can also try something like Docusate as well. Please, if they've had laxatives and they're not working after a few days, then please try enemas, please try glycerin suppositories. It's really uncomfortable and miserable. It can cause delirium and it can affect people's rehab potential. And in fact, there's one that I haven't mentioned that I just thought of, which is something called naloxegol, or Meventig, which is a special opioid receptor anti-constipating agent that's quite new. But if someone's failed on laxatives and their constipation is due to opioids, then Moventic or naloxone. I've tried it and it seems to work so far. Right, pain, and I know that people devote their entire careers to pain, and I'm about to devote 3 slides to this, so I should apologise if people disagree with what I've said. This is from my experiences working as an ortho-geriatrician and on the elderly care wards. So this is the pain ladder that we kind of all got taught at medical school. So non-opioid, weak opioid, strong opioid. Non-opioid, I have to say I haven't seen many people use aspirin, particularly in my patient group, elderly patients, risk of GI bleeds, I probably wouldn't be that keen. NSAIDs, Maheshi talked about NSAIDs in COVID the other evening. Also, please don't use it in people with renal failure. Please don't use it in the elderly. So again, I rarely prescribe NSAIDs. It is good for bone pain and probably for younger people. So basically paracetamol, and give it PRN or give it regularly. Please check their weight. Some people are under the weight where actually they should only be having 1 tablet 4 times a day. You can actually kind of overdose them. And then your weak opioid. So my preferred weak opioid is codeine, which is 30 to 60 milligrams and 4 hourly, maximum 4 times a day. Other people like tramadol. My only problem with tramadol is it's got a lot more breakdown products, so it acts on a lot more receptors. It's got a higher anticholinergic burden, which can cause delirium. But some people, if you ask them, will say, oh yes, I like tramadol, codeine doesn't work for me. And some people don't respond well to codeine. So that's the next bit. And you can also think about adding in non-opioids, so gabapentin or pregabalin, if you think, for example, that this is actually neuropathic pain, but you obviously need to ask about the pain. And then the strong opioid for moderate to severe pain. So what we normally start with is oral morphine as needed, 5 to 10 milligrams. And I just want to point a bit of caution that it's 5 to 10 milligrams, which is 2.5 to 5 mils. So there's 10 milligrams in 5 mils. Just be careful which one you're intending to prescribe. And please prescribe naloxone with it. Oxycodone is another morphine in a different form that you can take orally and is better for people with renal impairment, and that could be 5 milligrams 4 hourly. And you don't need to remember the doses of oxycodone and Oromorph off the top of your heads. Look it up, it's a controlled drug. What you can then do is add up how much they're using of this PRN stuff over the course of the day and convert it to modified release that they can take twice a day regularly, because we all know on the wards that people don't get the as needed medications as much as they perhaps could do. And it's got lots of different names, so MST, Zomorph, Morphgesic, but they are all modified release oral morphine. So I was specifically asked to look at the conversions, and there are loads and loads of conversion tables, and the BNF has quite a good one actually. But I found this and I quite like it, and I've got it on my phone now. So you can basically convert everything into milligrams of oral morphine, and you can kind of convert in from tramadol, and then you could convert out again to a buprenorphine patch, for example. So just to give you a worked example, let's say that our patient is on 60 milligrams of codeine 4 times a day, and they're taking 30 milligrams of breakthrough Oromorph, so that's what they're taking over the time. And you want to convert them to MST, which is the slow release form. So we go to codeine down here, and we say, right, what total dose of codeine are they taking? So they're taking 60 times 4, which is 240. 240 divided by 10 gives you their oral morphine that they're taking in the form of codeine, which is 24 milligrams. Add that to their 30 milligrams of breakthrough, and you get 54 milligrams. And you should always round a little bit down rather than up. So you would split that into 25 milligrams twice a day. And you would then make sure that they still got breakthrough stuff on the PRN, because you may find that they're using more. And in general, the breakthrough dose that you put on the PRN side is 1/10 to 1/6 of their daily dose. So this patient's daily dose is 50 milligrams. 1/10 of that would be 5 milligrams. So you would probably give 5 to 7.5 milligrams in every 4 hours. The other thing I would say is when you're in hospital, don't forget the pain team or special situations. So fractured noths, you can get things called fascial iliaca blocks that they can do. Rib fractures are becoming more and more commonly, we know, are a problem, and there are blocks that can be done for that. There are things like lidocaine patches that can be used for complex pain like shingles pain. So don't just keep cracking up with the morphine and think it's not working, it's not working, it's not working. There is support there as well. And just to know about discharging on controlled drugs, because this can be a real pain. So gabapentin and pregabalin are now also controlled drugs. You must prescribe so firstly, this has to be signed. So most hospital discharge summaries are now done on computer and just signed on computer. This you will have to print out and sign with your own pen. So you must prescribe the form. So whether it's tablets, capsules, liquid, so you can see this is capsule. And you must prescribe the total number to be supplied in words and figures. So 56 brackets, 56 capsules. And you need to prescribe the dose, which seems fairly obvious. And that doesn't need to be in words and figures, actually. So I could never remember this. I just used to write everything in words and figures and hope I'd got it right. So the dose doesn't need to be in words and figures, but you will often get asked by the ward pharmacist to do this, and it's worth in your mind when you're doing a discharge summary going, there's a controlled drug, I'm going to need to sign that myself. Okay, so I think I've got time for a quiz. So this is the case. So there's a 79-year-old man who's admitted with pneumonia. And for those of you who are interested, it's a curve 65 for pneumonia, which is bad, and sepsis. His lactate's raised at 3, so you give him some IV fluids, and you treat his pneumonia with amoxicillin and clarithromycin, as per the trust guidelines in your trust. You have to give it IV because he's drowsy and he's not able to swallow at the moment. He has an AKI stage 2. He's got a creatinine of 200, a urea of 20.2. His potassium is 6.8. And his sodium is 141. His liver function's normal. CRP is 300, white cell count's 20, and fitting with his pneumonia, and his hemoglobin's normal at 130. In his past medical history, he's got idiopathic Parkinson's disease, osteoarthritis, gastroesophageal reflux, hypertension, and heart failure with preserved ejection fraction. So that's a pretty standard A&E admission with lots of complications, basically. So these are his regular medications. So he's on Sinemet 62.5 micrograms 3 times a day, which is levodopa for Parkinson's disease. He's on Zopiclone 3.75 milligrams at night, sleeping tablet, Ramipril 2.5 milligrams, frutamide 20 milligrams, codeine 30 milligrams 4 times a day, torvastatin 40 milligrams at night, omeprazole 20 milligrams, and folic acid. I forgot to give you the dose, but it's 5 milligrams. Okay, so Kirsty, are we going to get the quiz thing? Is the quiz going to come up now? She says, hopefully.
Sure, so should be appearing just now.
Okay, so first question is, what would you do with his Parkinson's meds? He doesn't have an NG tube in. So you can hold them for tonight. You can reduce the dose because he's drowsy. You can convert to a reticotine patch using the optimal calculator, or you can give them PR.
Okay, so about half of you have voted. I'll give you a few seconds longer. Get those answers in. Okay, can you see this, Sarah?
Yeah, okay, great. Yay, everyone said convert to a reticotine patch. There are some things we can give PR. Aspirin is a good one in stroke, but converting to the reticotine patch is the correct answer. And that's what needs to happen. And you don't actually reduce the dose when they're drowsy. In the longer term, you may think about dose changes if people are hallucinating, but in the acute setting, you want him to be as mobile as possible. Okay, so next question. This is, you can pick as many medications as you want. Go mad. If he was able to swallow, so he's not drowsy now, he's able to swallow, are there any of these medications that you would withhold?
Okay, so the poll's busy with you all filling it in just a few more seconds. The question is, if he was able to swallow, are there any medications you would withhold? You can pick more than one. Okay.
Okay, so yay, lots of people have held lots of things. So I would hold his atorvastatin because we've got him on clarithromycin and they interact. I would definitely hold his ramipril because he's got AKI and he's got hyperkalemia. I would definitely hold his frusemide because he's got AKI and you think he's dry and you're giving him fluids. I would probably hold his codeine at the moment because he was sleepy. Although I agree that you need to think about pain. I would take his Zopiclone away forever and lock it up in the cupboard because I hate Zopiclone. But definitely at the moment he's drowsy and I don't think he needs it, and it's not great in Parkinson's disease anyway. I would let him have his folic acid and his Cinemet because I can't see that they will cause any particular harm. And some people might stop his omeprazole while he's on antibiotics because some people theoretically think there's an increased risk of C. diff. And I think that's when you can say to whoever's in charge, would you like me to withhold the omeprazole or would you like me to continue it? Okay, so I've been asked if we can go back to the case when we see each of the polls. I think it's quite difficult to do that, but hopefully you don't need the case now. This is more just of a pain question. So unfortunately, and we have to do a Ceri and it's all awful, he falls on the ward and he fractures his north. He then has it operated, and post-operatively you've asked to manage his pain, and we've done badly because we've just left him on his codeine 30 milligrams 4 times a day and nothing else. So what one thing would you do at this point if you can pick one of those 3 things? Would you add in paracetamol 1 gram QDS regularly? Would you prescribe ibuprofen 400 milligrams TDS? Or would you prescribe MST, which is modified release oral morphine, 10 milligrams twice a day?
Okay, add your final answers in just now.
Okay, so I think it's brilliant that no one prescribed the ibuprofen because A, I hate it, B, he's elderly, C, he's got acute kidney injury. I would add in the paracetamol 1 gram QDS regularly because actually what you've done is you've not started low down the pain ladder. And my reason for not giving the MST 10 milligrams twice a day is that's actually a reasonable amount. You'd probably be better off going up on his, adding in the paracetamol, then going up on his codeine, then adding in some PRN Oromorph, rather than going straight in at the MST 10 milligrams BD. So that's the rationale for adding in the paracetamol first. And I think this is the last quiz question. You've increased his pain relief, but now he's vomiting. This is what elderly care is quite like. Which of these can you give him? Ondansetron 20 milligrams IV 3 times a day, metoclopramide 10 milligrams IV 3 times a day, or cyclizine 50 milligrams 3 times a day. I acknowledge that none of these drugs are perfect and they've all got side effects and they've all got risks, but of those choices and doses, which would be the best to give?
Okay, if you put your final answers in now, please.
Great. Okay, so I'm sorry we didn't have the case up. So the reason we wouldn't give him metoclopramide is because he's got Parkinson's disease. It's an absolute no-no. The ondansetron 20 milligrams is a very, very, very high dose. So normally we'd give 4 milligrams IV, but again, I don't expect people to know that off the tops of their heads. You can always go and look it up in the BNF. So for that reason, the cyclizine 50 milligrams IV TDS is probably the best choice for him. Also, ondansetron is constipating, and you've just probably about to give him a load of constipating painkillers. So that might be another reason not to, but it's mainly that dose is not the dose we would use. So that was a really whistle-stop tour through the things that we thought would be helpful that haven't been covered already. These are just a few things that are quite useful. So the optimal calculator is the thing I was talking about for PD drugs. The BNF is so good, and you can get it on your phone. You can get it on the computer. It's got sections on warfarin prescribing. It's got sections on palliative care. This is MicroGuide, which is what my trust uses for its. Oh, my screen share has disappeared. What my trust uses for its antibiotics. And this, safeprescriber.org, has been suggested to me. It's got sort of apparently 47 modules where you can read up about common prescribing situations, and it's targeted at foundation doctors. So would probably be good for someone who's coming back in at an SHO level, having been out for a while. Oh, and I've just seen one question that I quite like to answer live, because it was absolutely my mistake for not saying this. Someone asked me what a NOAC stands for. I'm really sorry. Sorry, DOAC stands for. So DOAC stands for direct oral anticoagulant. They used to be called NOACs, novel oral anticoagulants, but they're A, not novel, and B, someone apparently once misinterpreted NOAC to mean no anticoagulation, which became a legal case apparently. So they're DOACs now.
Well, thank you, Sarah. That was brilliant. Your practical tips will be really helpful for those ward cover on calls. So thank you for taking the time to be with us again this evening. Fiona's done a fantastic job in the Q&A, answering the questions and also picking up with you from the diabetes talk earlier. So I think that's finished for the evening, unless there's anything you wanted to add.
Nope, that's it. I'm reading Fiona's answers now.
Well, thank you everyone for listening in tonight, and thank you to our speakers. Good night.
Good night.